Thank you, Suzanne, and thanks everybody in the committee for helping to support this study. We greatly appreciate it. I just start with the very human side. This is from one of the schools that we are dealing with. This is from Super Scholar Ruben at the Madison Elementary School, which is in the middle of Santana, which is where we're seeing a surge. And this was posted on the school Instagram. Hello to all my school friends. I hope you are doing well. I miss you all. Hope we see each other soon. Stay safe. Brief background, the schools closed at the start of the pandemic, and the data that suggested that they should close was really quite scant. More recently, the American Academy of Pediatrics, the National Academy of Medicine, and DMC recommends the school restart. And I say this with great caution and understanding that there's great controversy surrounding this. It's important to understand that disease severity in school-age children appears to be much less than in adults. We don't understand why that is. There's an important biological question here. And to quote my dear friend and colleague, Don Forthall, if we're really going to understand this pandemic, we have to figure out why the disease is less severe in children. The data that we have seen so far about whether children, in fact, have worse disease or spread it more rapidly come from Europe and Asia, which opened their schools. And they have not so far shown severe school-stimulated COVID outbreaks in general, but there have been outbreaks. And it's important to remember as we listen to all of the noise around this, that the schools in Europe and Asia did not simply return to status quo. Most countries implemented physical distancing, very stringent hand washing and face covering, and about 40% of European parents refused to send their kids back to school. As you can see in this picture in the lower right from Denmark, which already had only 20 students per school when only 60% returned, some of these mitigation strategies were easier to do under those conditions than what we have observed. And you know, the data are really nutty. This is a slide that was shown a couple weeks ago by the administration to say that, gee, there's been no problems when schools reopened, and they show the Norway data, and you can see here's when the shutdown in society began, here's when school began, and you can see that there was a continuing reduction in overall cases. But they didn't show you this, which was from Israel, where you had the shutdown, the reopening, and Israel struggling with a huge resurgence. Thousands of children, unfortunately, have been infected, as well as some students. So we put together a team to try to get at some of these fundamental research questions. I'd like to introduce everybody to Dr. Ulloa. She's a new recruit to CHOC and UCI. She's an outstanding physician scientist who's got a basic science program, mostly in bacteria, and she's just started literally, and she was too naive to say no, and I asked her to help me with this particular project, and she's been absolutely wonderful. She's finishing her her pediatric infectious disease fellowship at Children's Hospital Philadelphia. And this is a collective project where the ICTS through Diana Stevens has been contributing a tremendous amount. And CHOC has been a great partner. These are our two study coordinators at CHOC. Everybody's been working extremely hard to get the IRB ready, to get the manual procedures ready. This is not a simple thing to do, as you can imagine. Of course, the key issues is that there's mounting evidence that school closures have adversely affected health and learning of children and adolescents. We wonder whether children or adolescents become infected and sick when they re-aggregate in schools. What is the risk for school personnel? Can K through 12 students spark outbreaks throughout the neighboring communities? And of great importance is how do factors such as socioeconomics, race, ethnicity, and the special needs of our students affect COVID-19 as schools reopen? So the data is absolutely, we have to get data when schools reopen, and there's very little of that. But the hypothesis of the grant is that the effectiveness of California state and regional guidelines for reopening schools will be reduced in schools in lower socioeconomic neighborhoods. So we have two aims. Aim one is to measure the SARS-CoV-2 transmission in students and personnel and in selected schools as they reopen. Here's a really nice diagram from a recent issue of the American Journal of Physiology, which tries to understand from a biological perspective why children seem not to have a severe disease as adults. Again, we don't really know the answer to that. And our second aim is something that's often ignored, which is to measure the fidelity of mitigation. In other words, if you tell a kid or personnel even to stay 6 feet apart, do they actually do it? And we've adopted a novel system called the System for Observing Play and Leisure Activity in Youth to add to it direct observation of the success of mitigation. Additional research activities, because we're part of such a great research community here at UCI, include molecular phylogeny if we find positive cases, surveillance of co-circulating respiratory viruses. We're working with the BioFire company, which has just developed a new platform using nasal swabs to look at SARS-CoV-2 plus 20 additional co-circulating respiratory viruses, which may be better indicators of transmission than SARS-CoV itself. We want to look at maturationally dependent innate and adaptive immune responses that might explain some of the differences between children and adults. And as I mentioned, in the direct novel approaches towards the effectiveness of the mitigation. Very briefly, the 4 schools that we're looking at: public school in Santa Ana, where there's a current surge, a charter school in Santa Ana, a charter school in Orange that cares for students with special needs. This is a very important problem. You can imagine that the concept of physical distancing and caring for children with autism or Down syndrome, where literally the teacher or the aide has to be with the child when he or she is washing hands or going to the bathroom, is far different than might be encountered in general. And then we are also working with a private school in Newport Beach with a population of predominantly middle and upper middle class families. We've been at all these schools. The differences are quite remarkable. And finally, the chaos regarding schools reopening. So Governor Newsom stepped in 2 weeks ago and declared that in any suspect or watch list county, the schools could not reopen. However, in fine print, there was a mechanism for waivers, but in the 2 weeks that have evolved, there is no way that the schools can actually apply for these waivers. Hundreds of schools throughout Southern California have applied for these waivers. So if we have to do Plan B, we're going to start the study when distance learning starts. This will attest the assumption regarding the impact of physical closing of schools. And by this, I mean there's 1.2 million K through 12 children in Orange and LA County. And the idea that there is going to be no contact amongst them and between them and adults, when we know that all kinds of unregulated daycares are developing all throughout our community, is something that I can't be sure is in fact the case. And we want to assess physical activity and mitigation fidelity in the neighborhood. And we would continue the formal part of the study when schools reopen, having this very excellent comparison group. I'm open for questions.
Dan, is there any information about the rise in terms of numbers in Israel versus Norway? I mean, it's so different.
Yeah, I think that there is a good explanation for that, Addie. And what happened in Israel was a couple of things, that there are very big differences in the society. I think Israel, in many ways, is more like the United States, being relatively chaotic and not a society that people like to obey rules. And what happened was about 2 weeks after the schools reopened, there was a large heat wave in Israel. And all of the face masks and the social distancing went away. And as a result of that, you saw these large increases. So the success in Europe is probably more a testament to the ability of the schools to actually implement mitigation than sometimes had been made the case by the Orange County Board of Education and our administration, that they just let the kids willy-nilly return to school. And that's not what happened. And I think what the Israel shows you is that you really do need, and now I'm glad to see that folks up on high are starting to say, restart schools in a safe way, which is not what they were saying 2 weeks ago.
Dan, my mind boggles at the complexity of what you're trying to do here. Could you talk a little bit about how you're actually making these measurements and assessments, and about possible investigator bias if you're being called to also consult as an expert in this area? Do you anticipate schools will change their paradigm in the middle, after a few weeks?
So we're separating those functions, Suzanne. What Suzanne is referring to is that we felt a distinct obligation to help the schools develop their own plans. And we can talk for hours about the sad failure of the fact that most public schools don't have a plan yet, and private schools do. So the part of our little organization, the CHOC, the UCI CHOC, School Restart Group, that does the review of the plans is going to be distinct from those of us who are part of the research. And we've made it very clear that we have no opinion on whether or not the school should reopen. That's going to be up to the state and the local healthcare agency. That's out of our hands. We are working very, very hard on literally what we're going to do. We've been at each school. We're going to set up tents. We're going to have personnel from CHOC and UCI we're going to use an anterior nasal swab rather than the nasopharyngeal, which I think if we did that to the kids, within about 2 minutes, they would all sue us or something. We're going to ask as many of the kids as possible to agree to blood draws. I think a lot will, so that we can do serology. We're working with OCHCA to get background data in the neighborhood that OCHCA is supposed to be doing in terms of contact tracing and kids who don't consent for the study. We have submitted the consent form. It's going through the trust rely mechanism. There's been a lot of background work, as you can imagine, Suzanne, to get a consent form, how we're going to consent, and all these issues we're dealing with.
Does the consent form include genetic studies?
Of the individuals?
Yeah.
No.
Okay.
No, it's a very, that's a very sensitive issue, and we're dealing in many of these neighborhoods with people who are a little bit worried about sharing a lot of private information. So we decided we wouldn't do that.
Right. Okay, I think unfortunately we need to move on to not unfortunately, it'll be another interesting talk, but we do have to move on.